Doctor, welcome to our SGD presentation. Our topic is congenital hemolytic anemia. Thank you for watching. And this is our SGD members. Okay, chapter 1, introduction. Now let me introduce myself. My name is Leonyta Augustyne with last 3 digits 150. And I will explain the background of the student project that we made. So congenital hemolytic anemia is a type of anemia that is hereditary and develop after birth within 1 month and may reduce one's quality of life by shortening the life of erythrocyte before 120 days or before the new one was formed. It is also affect organs function disability, including splenomegaly, PKD, or pyruvate kinase deficiency, and some patients even diagnosed with HS or hereditary spherocytosis. 60% of congenital hemolytic anemia patients have HS, and also splenotomy was performed in 20% of HS, and 55% of CDA2, and in 60% of PKD patients. It is also proven that iron referral occurred in 31% of patients with membrane defects and in up to 82% of PKD patients. Considering all of that, it can be concluded that these matters needs to be discussed further. That is all from me. Next will be explained by my friend.
Hello, my name is Adisti Widyasari with your last digit of name 084. So the proper formulation of this paper is what is congenital hemolytic anemia, what is the etiology of congenital hemolytic anemia, how to evaluate patient with congenital hemolytic anemia, and what is the treatment and management of congenital hemolytic anemia, and also how is the prognosis of congenital hemolytic anemia. And then the objective of this paper is to understand about congenital hemolytic anemia in general, and etiology, about the evaluation, about the treatment, and also the prognosis of congenital hemolytic anemia. And also the benefit of this paper is to show information about congenital hemolytic anemia, to improve knowledge of the medical students, and also improve clinical prevention and treatment of congenital hemolytic anemia.
Hello, my name is Clairene Siemarga with last 3 digits of student number 134. Today I'm going to explain about the definition of congenital hemolytic anemia. Congenital hemolytic anemia, or CHAs, are a group of hereditary conditions in which lifespan of red blood cell was reduced or erythrocyte was prematurely removed from circulation. That's all from me, thank you.
My name is Rania di Parawita. With last 3-digit student ID number is 226. I will explain about the clinical manifestation. Congenital hemolytic anemias commonly exist in infancy or early childhood. It is believed that congenital hemolytic anemias are hereditary conditions caused by the shortened lifespan of red blood cells and premature removal of erythrocytes. Also genetic conditions including hemoglobin defect, enzymatic defects, and also membrane defects. In infants that attract attention are they have a significant proportion of hyperbilirubinemia that is far from what should have been expected in the newborn period. It is noted that the symptoms may be so limited and can be undetected and only can be seen when it is in a mild form. And patients of any age can be present of chronic extravascular hemolysis, pallor, anemia, jaundice, splenomegaly, dark urine, and a variable degree of anemia. Alternately, the patient may show signs of anemia, hyperbilirubinemia, and reticulocytosis during periods of intense hemolysis. Congenital hemolytic anemias often cause a mild to moderate chronic level of hemolysis with increased reticulocytosis, but in severe form, congenital hemolytic anemias can be present but are rare.
Putu Adisti Cecilia Sujana with her last digit name is 241. I'll be continuing the explanation about the etiology of the congenital hemolytic anemia. So there are 3 conditions that cause this anemia. The first one is the hereditary spherocytosis, which is due to genetic abnormalities in the membrane or cytoskeletal proteins involved in structural morphologic stability. These atypical erythrocytes are unable to maintain their regular biconcave form. The second one is the hereditary elliptocytosis, which is genetic changes in some proteins in red blood cell, in peripheral circulation, which cause they lose their ability to elastically recoil and giving them an elliptical shape. The next one is the G6PD deficiency, which is the most common enzyme defect. This effect varies from normal with no clinical effects to severe deficiency, leading to persistent hemolysis and decrease of red blood cell lifespan. That is all from me. Thank you.
My name is Karen Angela, and my last 3 digits SGD number is 116. So in general, the pathophysiology of congenital hemolytic anemia is due to processes which are due to membrane and cytoskeleton defects, enzyme defects, and hemoglobin defects. In membrane and cytoskeleton defects, gene mutations lead to an alteration of the membrane shape, thus making either the spleen breaks the cells prematurely or the membrane shape alteration directly impacts on hemolysis. Some examples of the diseases that fall under this category are hereditary spherocytosis, hereditary elliptocytosis, and hereditary pyropoikilocytosis. Contrastingly, in enzyme defects, oxidative stress caused by unmetabolized reactive oxygen species, such as in G6PD enzyme deficiency, directly impacts on hemolysis. On the other hand, an undersupply of ATP, for example, in pyruvate kinase deficiency, also alters the blood cell shape, which not only promote premature breakdown by the spleen, but also hemolysis as well. Last but not least, hemoglobin defects, for example, in thalassemia, creation of the inclusion bodies will trigger the spleen to break the cells prematurely, and even worse in beta thalassemia, the bone marrow will destroy the erythrocyte precursor as well. Meanwhile, in sickle cell anemia, when induced with hypoxia, the erythrocyte will alter to a sickle cell shape as a result of a change in the hemoglobin shape, which similarly also lead to hemolysis.
Thank you for the opportunity. My name is Gede Saputra with the last 3 digit number of name 018, and I would like to discuss with you guys about the diagnostic feature of congenital hemolytic anemia. In diagnosing congenital hemolytic anemia, we will look for both of the physical manifestation and laboratorical feature. It is a common knowledge that hemolytic anemia patient will have splenomegaly and jaundice. Splenomegaly is a spleen enlargement due to the overworking of spleen for recycling defect and damaged RBC via the macrophage pathway. Jaundice happen because there is a lot of hemolytic process that trigger heme degradation pathway and producing an abundant amount of bilirubin. To further confirm the diagnosis, we'll also do a laboratorical testing in which there are 5 laboratorical features that is unique to congenital hemolytic anemia patient. First one is of course anemia, where the patient have low hemoglobin level of under normal range of 14 to 24 mg per deciliter. Patient will also show signs of hyperbilirubinemia. As I said before, they have an increased amount of unconjugated or indirect bilirubin over 0.8 mg per deciliter. Patient will also show signs of reticulocytosis or an elevated amount of reticulocyte count that is above 2 to 6%. Other laboratorical finding will also show signs of elevated lactate dehydrogenase or LDH. LDH is a byproduct of anaerobic metabolism in which show signs of somatic cell doesn't get enough oxygen to do the aerobic pathway. And finally, last but not least, there is also a decrease in haptoglobin. What is the haptoglobin? Haptoglobin is a protein carrier that carry defect and damaged RBC to the reticuloendothelial pathway in the spleen. So haptoglobin will react with this defect RBC and lowering its concentration.
Hello, my name is Gusti, Agung, Saraswati. My last 3 digits number 056. Now I will explain about differential diagnosis. The signs and symptoms of hemolytic anemia are very different, usually caused by anemia. Hemolytic anemia has several symptoms, namely acardia, dyspnea, abdominal pain, neurological sign, kidney failure, and thrombocytopenia. So it is often diagnosed with a differential diagnosis, namely disseminated intravascular coagulation, physical medicine, and rehabilitation for systemic lupus erythematosus and thrombotic thrombocytopenic purpura. That's all for me. Thank you.
Hello, doctor and friends. My name is Geraldine with the last 3 digits of student ID is 100. So I'm going to continue about the laboratory diagnosis. So in some cases, congenital hemolytic anemia is also often diagnosed as hemolytic disease of the fetus and newborn, or HDFN. The hemolytic disease of the fetus and newborn is basically a red blood cell mediated immune disorder in which maternal antibodies attack the erythrocytes of the fetus and newborn. This attack causing the erythrocytes to prematurely break down and later causing anemia and jaundice in newborn. Some clinical signs that make these two diseases similar are anemia, jaundice, and hepatosplenomegaly. That's all from me. Thank you.
Hello, my name is Anjani Prabandani with last three digits 148. So I will explain about the treatment and management of congenital hemolytic anemia. The first is corticosteroid therapy. Corticosteroid therapy can be given to patients with hemolytic anemia, especially extrinsic hemolytic anemia caused by autoimmune. And next is immunoglobulin injection. Intravenous injection of immunoglobulin can be done to suppress the immune system if the hemolytic anemia is based on autoimmunity. The third is drug avoidance. Avoiding the use of some drugs, such as cephalosporin, penicillin, NSAID, and others, because the use of those drugs could lead to hemolytic anemia. And then is transfusion of red blood cells. Red blood cell transfusions are given to increase the number of red blood cells quickly and replace the damaged red blood cells before with the new ones. And then is splenectomy. Splenectomy is a surgical procedure to remove the spleen. Removal of the spleen could reduce the rate of red blood cells being destroyed. It usually used an option in case of the other treatment do not respond in this session. That's all from me. Thank you.
My name is Tiffany Cecilia. Now I will explain about the complications of congenital hemolytic anemia. So hemolytic anemia can affect multiple organ systems throughout the body. In sickle cell disease, the chronic hemolysis that occurs reduces the amount of oxygen that can be delivered, further leading to tissue hypoxia. Risk of ischemic and thrombotic complications are also seen in any cases of hemolysis as complications due to toxics of circulating free hemoglobin and iron have been investigated. Excess hemoglobin and iron from hemolysis can also cause kidney complications. Both liver disease and neuropathy can lead to Wilson's disease if not diagnosed and treated early. Hemolysis is one of the most important symptoms in children and young adults with Wilson's disease.
My name is Nathanael Dihardja, with the last three digits of my student's number are 216. Now we will move to the prognosis of congenital hemolytic anemias is based on the patient's condition and the disease severity. If it is stable, it doesn't need treatment and will have a good prognosis. However, the patient may experience reduced survival of circulating red blood cell because of elevated levels of hemoglobin in the blood by enhanced red blood cell synthesis. In several cases of G6PD patient deficiency patients are likely to have baseline anemia, radiculotic, with or without jaundice that leads to a poor prognosis. Hemolysis happens when there are stressors and extreme activity between 10 and 60%. However, stressors like drugs and infection can cause severe hemolysis that necessitates blood transfusions. In newborns, the disease can cause hereditary erythrocytosis and hereditary spherocytosis, which is a poor prognosis. HE is characterized by a moderate to severe hemolytic anemia with high fermentation. This can cause mutations and phenotypic disease with reduced membrane stability and increased erythrocytic RBC substability. Mild to severe hemolytic anemia and decreased membrane surface area also increase osmotic fragility, which is the hallmark of HS.
Thank you for the opportunity. My name is Rosevelani, and now I will be presenting about the conclusion of our student project. So, congenital hemolytic anemia, or CHA, are a group of hereditary conditions in which lifespan of red blood cells was reduced. The pathophysiology are cytoskeleton defects, enzyme defects, and hemoglobin defects. The gold standard for the diagnosis of CHA are complete blood counts and peripheral blood smears. The laboratory manifestations are abnormal RBC morphology, low hemoglobin level, high LDL, and high unconjugated bilirubin. The differential diagnoses are disseminated intravascular coagulation, systemic lupus erythematosus, and thrombocytic thrombocytopenia purpura. The treatment are corticosteroid, immunoglobulin IV administration, avoiding some drugs, RBC transfusion, and splenectomy. The complications for CHA are tissue hypoxia, ischemic and thrombotic complications, kidney, liver, and neuropathy disease, and recurrent cholelithiasis. The prognosis are based on disease severity, which is good for mild CHA and bad for G6PD patients and newborn. So that's the presentation of our student project entitled Congenital Hemolytic Anemia. Thank you for the attention. I would like to close the presentation with Paramasanti. Om Santi 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 Om.